Welcome to Chapter 4, and this chapter, what we're going to be covering are atrial rhythms. So just as a reminder, our atria or atriums are thin-walled, low-pressure chambers that receive blood from the systemic circulation as well as the lungs. Now, there is normally a continuous flow of blood from the superior as well as the inferior vena cava into the atria. Now, you may hear the term atria kick, and what this describes is typically about 70% of this blood that is coming in, that continuous flow from the superior and inferior vena cava, 70% of that is going to flow directly through the atria and into the ventricles before the atria even contract. However, 30% is going to be withheld, and when the atria contract, that additional 30% is going to be added to the ventricles, and that's what's considered that atrial kick. So that 30% that's held back from that continuous flow from superior inferior vena cava into the atria and then into the ventricles, that 30% that kicks in when the atrium or the atrias contract is going to be that atrial kick. So a few things that I just sort of want to remind you of and sort of summarize from our previous lectures before we continue on. So first thing I want you to remember is that the P wave is always going to represent atrial depolarization. So remember, when the atria are contracting, that is showing on the ECG as a P wave. I also want you to remember that a rhythm that begins in the SA node has one positive, meaning it's an upright. All right, so that little P wave is on the top of the line, not below the line, before each QRS complex. Also, when a rhythm begins in the atria, it will always have a positive P wave that is shaped differently than P waves that begin in the SA node. So this difference in the P wave configuration occurs because the impulse begins in the atria and then it follows a different conduction pathway to the AV node. What atrial dysrhythmias reflect or represent is an abnormal electrical impulse formation and conduction in the atria. They can result from a few different things like abnormal automaticity, triggered activity, or even re-entry. So abnormal automaticity is and triggered activity are going to be disorders in impulse formation, whereas re-entry is a disorder in impulse conduction. Dysrhythmias caused by disorders of impulse formation are going to be often referred to as automatic, where dysrhythmias that are caused by a disorder in impulse conduction are referred to as reentrant. So abnormal automaticity occurs in normal pacemaker cells as well as in myocardial working cells that do not normally function as pacemaker sites. So with abnormal automaticity, these cells fire and initiate impulses before normal SA node impulse. So if that rapid firing rate occurs for more than 50% of the day, it is said to be incessant. And that rapid firing rate may also occur periodically. And in these cases, it is said to be episodic. So atrial dysrhythmias associated with abnormal automaticity include things like PACs, multifocal AT, and atrial fibrillation, or what we call AFib. Triggered activity is going to result from abnormal electrical impulses that sometimes occur when the when the heart is at rest. So during repolarization, so when that area is refilling. And this is normally when those cells are quiet. Triggered activity also occurs when escape pacemaker and working cells fire more than once after stimulation by a single impulse. Triggered activity can also result in atrial or ventricular beats that occur alone, in pairs, in runs of 3 or more beats, or as a sustained ectopic rhythm. Now, in reentry or reactivation, this is a condition where an impulse returns to stimulate tissue that was already stimulated. So it was previously depolarized, and it's coming back, re-entering or reactivating what was already depolarized or activated. Now, what happens when this reentry occurs is a single premature heartbeat or a repetitive electric impulse in short periods of rapid rhythms is what we'll sort of see in regards to this reentry. So normally our impulse is going to spread through the heart only once after it's initiated by the pacemaker cells, right? So typically our pacemaker cell initiates that impulse. It travels through the conduction system normally. All right, on our ECG, we see a normal heartbeat. We see our P wave, our QRS complex, followed by our T wave. All right, but when we have reentry, or what we might call it reactivation, that electrical impulse is going to be delayed. It may be blocked, or both in one or more areas of the conduction system while being conducted normally through the rest of the system. So this then is going to result in the delayed electrical impulse entering the cardiac cells that have just been depolarized by the normally conducted impulse. So, if that delayed impulse stimulates an area that is relatively refractory, if I can speak today, sorry, that impulse can cause those cells to fire. So what this then can happen is this can produce a single early or premature beat or even repetitive electrical impulses, which results in short periods of rapid rhythms, what we may call tachydysrhythmias. So as you can see on this chart here, all right, on the top left here, we see a normal conduction, all right, conduction, all right, and then what we see to the top right is that re-entry. So, right, so we see the arrows going back and forth. Up here, we see that, and then that conduction is blocked. Now, as you see on the left here as well, you can see where the impulse is arriving and it smoothly travels through. Where on the right hand, you can see, if you're looking at number 1 on the right hand side of the slide here, what you'll see is there's a block here. So what happens is that impulse is starting to arrive, it's working its way through, and then it reaches this block. And what happens when this block occurs is now we're going to see the system work as its own pacemaker. And what happens this time is what we see is a rate that is usually a lot higher than our normal sinus rhythm. Now, most atrial dysrhythmias are not life-threatening for the most part, but some may be associated with some extremely fast ventricular rates. Increases in heart rate shorten all phases of the cardiac cycle, but the most important is a decrease in the length of time spent in diastole. So remember that as the heart rate increases, there is less time for the ventricles to fill and less blood for the ventricles to pump out with each contraction. Therefore, an excessively fast heart rate can decrease our cardiac output. So there's different factors that can go into or influence heart rate. And this it can be things that include hormone levels, such as thyroxine, epinephrine, norepinephrine medications can also affect, as well as stress, anxiety, fear, and even our body temperature. Now, the term complex, as we start talking about premature complexes, the term complex is used instead of contraction. And this is because we want to correctly identify an early beat because the ECG is going to depict electrical activity, not mechanical function of the heart. You will hear some practitioners prefer the term conduction instead of complex. So a premature beat means that it appears early. So it appears before it is expected. Now, these premature beats are identified by their site of origin. So we may have a premature atrial complexes, which are PACs. We may have a premature junctional complexes, PJCs, or we may even have a premature ventricular complexes, which is a PVC. So this is where that site happens. Wherever it arrives early, all right, that site is how we determine or identify what that premature complex is. So now we're going to touch base a little bit about premature complexes and their patterns. So the first thing I want to talk about is these paired beats, or what we call a couplet. And these are two premature beats that show on the ECG in a row. So two premature beats that show in a row. We also have what we call runs or bursts. And what qualifies as a run or a burst is 3 or more premature beats in a row. Bigeminy is going to be every other beat is a premature beat. So once again, bigeminy is every other beat is a premature beat. Now, trigeminy is every third beat is a premature beat. So what I want you to think of is bigeminy, think of like a bicycle. It has 2 wheels, so every other beat. Trigeminy, think of tricycle, every third beat. And then quadgeminy, what we're going to see or every fourth beat is a premature beat. So quad equals 4. So that can sort of help you maybe remember what those are a little bit as we're going through all these different, all this new information for you. Now, a PAC occurs when an irritable site, like a focus, within the atria fires before the next SA node impulse is expected to fire. What this does is this interrupts the sinus rhythm. So if that irritable site is close to the SA node, the atrial P wave will look very similar to the P waves initiated by the SA node. The P wave of a PAC may be biphasic, which can mean partially positive, partially negative. It could be flattened, maybe even notched. It could be pointed, or even lost in the preceding T wave. On the next slide, we'll go into how we recognize these and look at a sample ECG on this. So now we're going to talk about how we can recognize these premature atrial complexes or contractions. So when we are compared with the PP intervals of the underlying rhythm, a PAC is going to be premature and it's going to occur before the next expected sinus P wave is supposed to occur. Now, how we're going to notice or recognize them are going to be that we're going to see an early premature P wave. That positive upright P wave in lead 2 is still going to exist, but it may differ in shape from that sinus P wave. We may also see early P waves that may or may not be followed by a QRS complex. So in a PAC, what we're going to see is it's going to have a positive P wave before that QRS complex, and sometimes that P wave may be clearly seen, and sometimes it may not. So in the P wave of an early beat, if it's not obvious, what we should do is look for it in the T wave of that preceding beat or the beat before. The T wave of the preceding beat may be of a higher amplitude, so that little wave might be much higher, or hump, excuse me, may be much higher, which suggests the presence of a hidden P wave, basically. So as we're looking at this ECG strip up here, what I want you to look at is beat number 2. So remember, a beat is going to consist of a P wave, a QRS complex, and a T complex. So what we see is our first beat here. As we move to our second, look at that P wave. Look how it's elevated. Then we have our QRS complex. As we follow along, we see normal beats in beat number 3, 4, 5, 6. But as we get to 7, see how there's a beat that's occurring much quicker than it has in these last few beats. And we also see another elevated P wave. Then we go back to a normal rhythm. And then as we get over to beat number 10 here, we see another elevated P wave and a beat that occurs at a faster rate than what we see in the normal sinus rhythm within this strip. So when we break down the actual characteristics of this ECG, we're going to notice that the rhythm is going to become irregular because of these early or premature beats. We're going to notice that the range is usually going to be normal range. However, that can depend on other things going on, like underlying rhythm. As far as these P waves, this is going to be the big red flag here for you, is they're going to be premature, occurring earlier than what should be expected for the next P wave. It's positive and upright, and it should one before each QRS complex, but they are going to often differ in shape from the sinus P wave. So remember, sinus is our normal P wave when we're in normal rhythm. They also may be flattened, notched, pointed, biphasic, or even lost in that preceding T wave. So that's what we're sort of looking for. And once again, as an example on this ECG strip here, is beats 2, 7, and 10. Our PR interval may be normal, or it could also be prolonged. We may see usually with our QRS duration, 0.11 second or less, but it could be widened or even absent depending on the prematurity of that beat. Now, as far as the interpretation of this ECG, this is going to show a sinus tachycardia at 111 beats per minute with 3 PACs. Once again, those PACs are going to be beats number 2, 7, and 10. So you're also going to hear the terms compensatory and non-compensatory pauses. So a non-compensatory or incomplete pause is often going to follow a PAC. And what this represents is the delay during which the SA note is going to reset its rhythm for the next beat. So that's where we see an incomplete pause. The SA note is resetting itself before the next beat. In a compensatory beat, it's going to be present if the period between the complex before and the complex after a premature beat is the same as 2 normal RR intervals. So that's how we would tell the difference between these two. So in here, what we're looking at here is sort of continuing off our compensatory and non-compensatory pauses. So this sort of gives you a really good visual of sort of like what we're looking at in regards to those. So a premature ventricular complex, or what we call a PVC, is often going to be followed by a full compensatory pause. And that is what you're going to see in A here, okay? Where in B on this picture, a premature atrial complex, or the PAC, what we were just sort of talking about, and looking at the ECG strip, that is often going to be followed by a non-compensatory or an incomplete pause. So you can see the two difference here between A and B. So our top one here, once again, is a full compensatory pause, where B is a incomplete or non-compensatory pause. So as we look at this ECG strip here, it's going to help us see what a non-compensatory pause is and where it's present. So as a reminder, it's going to be present if the period between the complex, before and after a premature beat, is less than 2 normal RR intervals. So a PAC, or a premature atrial complex, is present here. So as we look at this, what you'll notice is we have our first beat, we have our second beat, which is our PAC. You can tell here by the elevated P wave. Then what you'll notice is there's a long pause. That is our non-compensatory pause. Then we get back to our normal sinus rhythm in beats 3, 4, and 5. And that is 2 RR intervals of normal rhythm, all right? So from R, so the top, remember Q is the bottom, R is our big waves to the very top. So if we go from 1, so from beat 1 or 3, 4, and 5, that is 2 normal RR intervals. So aberrantly conducted PACs are typically going to be associated with a wide QRS complex that are called aberrantly conducted PACs. And what this indicates is conduction through ventricles is abnormal. So if a PAC occurs very early, the right bundle branch can be slow to respond to that impulse or that refractory. So that impulse travels down that left bundle branch with no problem. The stimulation of the left bundle branch subsequently results in stimulation of the right bundle branch. So the QRS will appear wide, so greater than 0.11 seconds, because of the delay in the ventricular depolarization. So PACs associated with a wide QRS complex are once again going to be called those aberrantly conducted PACs. So as you can see on this ECG here, we have a PAC that is conducted normally. And then we also have a aberrantly conducted PAC. You see this wide QRS complex, where with our conducted normally PAC, you see a normal QRS complex. Now, sometimes when a PAC occurs very early and close to the T wave of the preceding beat, only a P wave may be seen with no QRS after it, so it appears as a pause. So this type of PAC is called a non-conducted or a blocked PAC because the P wave occurred too early to be conducted. So non-conducted PACs occur because the AV junction is still refractory to stimulation and it's unable to conduct that impulse to the ventricles. That's why we don't see the QRS complex. So what we can do is look for the early P wave in the T wave of the preceding beat. So as we look at this ECG strip here, what we're going to notice is we have our P wave, QRS, and then we're going to start to see our PACs. And within that, we're even seeing some PACs that are missing a QRX complex. For example, right after our first beat, we have an elevated P wave, right, or T wave here. And it's, as this wave right here is elevated, we don't have a QRS complex in between. That is what we're talking about in regards to our non-conducted PACs. Now, in sinoatrial block, an entire PQRST cycle is missing, and there is no distortion whatsoever of the T wave preceding that pause. So a non-conducted PAC may appear as a P wave with no QRS after it, or that T wave of the beat preceding the pause may be of higher amplitude than the other T waves, or it might even have an extra hump, suggesting the presence of that hidden P wave. So because both those dysrhythmias have a pause associated with them, how could you differentiate between a sinoatrial block and a non-conducted PAC? That's your answer. So what can cause PACs? What causes them to occur? There's going to be a lot of different things, such as acute coronary syndromes, our atrial enlargement, so enlargement of our atrium or atrias, digitalis toxicity, electrolyte imbalance, even emotional stress, heart failure, hyperthyroidism, mental and physical fatigue, things like caffeine and tobacco or even cocaine. Some other medications, as well as valvular heart disease. So we've looked at the ECG, and now we see our patient has PACs. What do we do about it? So first, PACs are usually not going to require treatment if they are infrequent. However, for those PACs that are frequent, the patient may notice a skip beat or even occasional palpitations. And some patients may be unaware of these occurrences as well. However, in our susceptible individuals, these frequent PACs may induce episodes or cause AFib or even proximal supraventricular tachycardia, which is what we call PSVT. Now, what we do when we have a patient that has frequent PACs is what we're going to do is work on treating those underlying causes. Things like if there's electro imbalances that are present, we want to correct those. Assist our patients with reducing any stress that may be present in their life. Reduce or eliminating any stimulants like drugs or tobacco. And treating heart failure if that's the case. Now, in patients that are symptomatic with frequent PACs, we may even treat them with some medications as well, with some different types of beta blockers like atenolol or metoprolol. Now, multiform atrial rhythm is an updated term for the rhythm that we used to call wandering atrial pacemaker. So with this rhythm, the size, the shape, and the direction of the P wave is going to vary, sometimes from beat to beat. So the differences in the look of the P wave is a result of that gradual shifting of the dominant pacemaker among the SA node, the atria, and even maybe the AV junction. So the wandering atrial pacemaker is going to require at least 3 different P waves seen in the same lead for proper diagnosis to occur. So how do we recognize this? So the biggest thing is we're looking at the different shapes of the P waves. So as you can see here in our ECG, there's arrows that are pointing to the different P waves here. So if you look at beat 4, 5, and 6, we have different shapes of the P waves compared to our other P waves within this ECG strip. So as far as other characteristics that we're looking at, usually the rhythm is going to be irregular as the pacemaker site shifts from the SA node to other ectopic atrial locations or even that AV junction. Now, our rate is usually going to be normal, but it can sometimes be slower as well. If it is faster than 100 beats per minute, the rhythm is going to be termed multifocal atrial tachycardia. Once again, the P wave is where we're going to see the big difference here in our wandering atrial pacemaker. The size, the shape, and even the direction may change, as you can see by beats, once again, 4, 5, and 6 on this ECG. That PR interval is going to vary as that pacemaker site shifts, and our QRS duration is typically going to be that 0.11 second or less, unless there's something that's being abnormally conducted. Now, what can cause this wandering atrial pacemaker? Um, first of all, this may be observed in normal healthy hearts, even in athletes and sometimes during sleep. We may also see it occur with some types of underlying heart diseases and even with that digitalis toxicity. So this dysrhythmia usually produces no signs and symptoms whatsoever unless it is associated with a slower heart rate. So typically with the wandering atrial pacemaker, we're not going to see any signs or symptoms that are associated with it unless we may see a slow heart rate. So usually it's going to be classified as what we call a transient rhythm, and that's going to basically resolve on its own when that firing rate of the SA node increases and that sinus resumes the pacing responsibility. However, if we're seeing the wandering atrial pacemaker occur because of the digitalis toxicity, then we would withhold that medication to treat this. When that wandering atrial pacemaker rhythm is associated with a ventricular rate of more than 100 beats per minute, that is when this dysrhythmia, we're going to switch the name. It is going to have a different diagnosis of multifocal atrial tachycardia, or MAT. And what this is the result of the random and chaotic firing of multiple ectopic sites in the atria. So how do we recognize it, right? So as we look at this ECG and we looked at the characteristics of this, what we're looking at is, one, the rhythm is going to be irregular. As that pacemaker site shifts from the SA node to the ectopic atrial locations or even that AV junction. Once again, the rate, remember tachycardia, higher or faster heart rate. So it's going to be faster than 100 beats per minute, as you can see in this ECG. Our P waves, the size, the shape, and the direction may change from beat to beat, just like what we talked about with the wandering atrial pacemaker. They also might be upright, inverted, biphasic, rounded, flat, pointed, notched, or even buried within that QRS complex. That PR interval is going to vary, and the QRS duration is going to be the same as that wandering atrial pacemaker. The big difference that we're seeing here is the rate compared to the wandering atrial pacemaker. So what can cause this? Most often what we're going to see is those that have COPD, or what we call chronic obstructive pulmonary disease. It can also be in patients with acute coronary system, valvular heart disease, or hypomagnesemia. It also could be a precursor or a sign of AFib, or atrial fibrillation. So what do we do about it? A lot like what we do with a lot of these others. What we're going to do is we're really going to work on treating that underlying cause. If that patient is symptomatic, we want to make sure that we consult a cardiologist before any treatment started, to make sure they're looking at the big picture of everything in regards to this. Now we're going to move into supraventricular arrhythmias. And these begin above the bifurcation of the bundle of His. So what this means is that the supraventricular arrhythmias include arrhythmias that begin in the SA node, the atrial tissue, or even the AV junction. And the term supraventricular tachycardia, SVT, includes supraventricular rhythms with a ventricular rate faster than 100 beats per minute at rest. So now we're going to get into the different types of supraventricular tachycardias. So as you look at A, that's going to be a picture of our normal sinus rhythm, just as sort of a reference for you as we begin to look at these other ones. As we move to B, what you're going to see here is atrial tachycardia, or what we call AT. And what you'll notice is we have a little X in that picture, right? So what happens is a focus, that X, is outside of the sinoatrial, that SA node, and it fires off automatically at a rapid rate. So if you'll notice, if we look at the normal sinus rhythm, then we look below B, you see it's a much faster rate here. Now as we move to C, we're going to look at our atrioventricular nodal reentrant tachycardia, also known as AVNRT. Nice and long for you to remember, right? So what happens here is the cardiac stimulus is going to originate as a wave of excitation that spins around that AV junction area. So you'll notice that circular motion here. And what happens when this occurs is the P wave may be buried in the QRS complex, or it might even appear immediately before or just after the QRS complex because of the nearly, basically what happens is the atria and the ventricles are being activated simultaneously or at the same time. So you'll see there's arrows here that sort of show that it's being buried either within the QRS or directly before or directly after. We're not seeing that upright P wave. Now, as we move to D, what this is this is a atrioventricular reentrant tachycardia, AVRT. And what you'll see is you'll also see a little arrow that points here to what you're going to notice in the AVRT rhythm. And we're also seeing the P wave after that QRS complex. All right. And you'll notice it has a very similar circular motion. Now, what you'll notice is some of these CVTs or supraventricular tachycardias need the AV node to sustain the rhythm, and some may not. For example, in the AVNRT and the AVRT, they require that AV node as part of the reentry into the circuit or that circular motion to continue that tachycardia. Where other SVTs use that AV node not only to conduct the rhythm to the ventricles. So for example, what we'll see is, let me rephrase that last one. I don't want to confuse you. So these other SVTs, what you're noticing is they're using that AV node only to conduct the rhythm to the ventricles. So what you'll see is an atrial tachycardia, atrial flutter, and AFib or atrial fibrillation. These are going to arise from a site or sites within the atria. They do not need that AV node to sustain the rhythm. AT, or atrial tachycardia, is going to be a regular rhythm that arises from an ectopic focus in the atria at a rate of 100 beats per minute or faster, and it's not going to require that AV node to maintain the dysrhythmia. So what happens is that rapid atrial rate is going to override the SA node, and it's going to become the pacemaker. So AT is going to often be precipitated by a PAC, and when there are 3 or more PACs that occur in a row, at a rate of 100 beats per minute or more, the AT is present. So with AT, the conduction of the atrial impulse to the ventricles is often 1-to-1. So what that really means is that every atrial impulse is conducted through the AV node to the ventricle. And what this results in is the P wave will precede each QRS complex. Now, although that P wave appears upright, they tend to look different from those seen when the impulse is initiated from the SA node. Now, it is possible for an AT to have negative P waves in those inferior leads if it arises from the lower part of the atrium. Because conducted impulses travel through the ventricles in the usual manner, the QRS complexes are going to appear normal in these as well. So in this, you can see a good picture that is sort of showing you normal sinus rhythm on the left and then the atrial tachycardia on the right. Sort of helps give you a good picture of what this may look like. So to dive in a little bit deeper on this, how do we recognize AT or atrial tachycardia? So paroxysmal supraventricular tachycardia that ends spontaneously with the abrupt resumption of sinus rhythm. The P waves of that tachycardia, which is about 150 beats per minute, are superimposed on that preceding T wave. So the term paroxysmal is going to describe a rhythm that starts or ends suddenly. So AT that starts or ends suddenly is called paroxysmal supraventricular tachycardia, or PSVT. Once it was also known as paroxysmal atrial tachycardia. Now, PSVT may last for minutes, hours, or even days. And if the onset or end of PSVT is not observed on the ECG, the dysarrhythmia is simply just going to be called an SVT. So when we're looking at the ECG characteristics, we're going to notice that the rhythm is going to be regular. Our rate, because we're in tachycardia, is going to be anywhere from 101 to 250 beats per minute. P waves are going to be what we really look at here. One P wave is going to precede each QRS complex and lead 2. And these P waves are going to differ in shape from the sinus P waves. We might see an isoelectric baseline, and it's usually present between P waves. Now, if the atrial rhythm originates in the low portion of the atrium, we may notice that P wave is negative. We may even have a difficult time distinguishing between the P wave and the T wave because of that rapid pulse as well. Our PR interval, may be shorter or longer than normal, just depending. And our QRS duration is going to be the same as we've talked about. So on this ECG lead, you're going to see AT at the beginning. And then it's going to transition into sinus rhythm. So you notice in AT, we have several more beats within this part of the ECG than we have within our sinus rhythm. So that's going to be a huge part of our rate characteristic in our AT. You'll also notice our P waves have different shapes and sizes within our AT as well. Now, there's also different types of blocks. So atrial tachycardia with a 2-to-1 block. These are P waves that are going to be clearly seen before the QRS complex. And then others may be hidden in T waves. And the atrial rate is going to be 180 beats per minute, while the ventricular rate is going to be 90 beats per minute. Now, with these very rapid atrial rates, the AV node begins to filter some of the impulses coming to it. So by doing that, what it's doing is it's protecting the ventricles from excessively rapid rates. When the AV node selectively filters the conduction of some of these impulses, the rhythm is going to be called paroxysmal supraventricular or atrial tachycardia with block. So PSVT with block is often going to be associated with a disease of the AV node. It could be associated with medications that slow conduction through the AV node or even digitalis toxicity. When the PSVT with block exists, more than one P wave is going to be present before each QRS. So when that AV node blocks every other atrial impulse from traveling to the ventricles, the rhythm is called PSVT with 2-to-1 block. So what can cause AT? Now, this is important to know that this can occur in people with normal hearts or in those with some type of organic heart disease. It may be related to an acute event or it may not. So some things that may cause it are things like acute illness with excessive catecholamine release, digitalis toxicity, electrolyte imbalance, heart disease such as coronary heart disease or CAD, valvular disease, cardiomyopathies, or even congenital heart disease. Other things like infection, pulmonary embolism, or even any type of stimulant that could be used like caffeine, albuterol, theophylline, and cocaine could all cause AT to occur. Now, the signs and the symptoms that are experienced by a patient with tachycardia are going to depend on the ventricular rate and how long the tachycardia lasts, as well as the patient's general health and the presence of any other different types of underlying or chronic heart diseases. The faster the heart rate, the more likely the patient is to have signs and symptoms resulting from that rapid rate. So some things that we may see are active changes in mental status. They may be asymptomatic, meaning they don't have any signs or symptoms. They could also have dizziness and lightheadedness, dyspnea, which means they're having difficulty breathing, fatigue, fluttering sensation in the chest. They might have hypotension or low blood pressure, ischemic chest discomfort, palpitations, signs of shock, syncope, or even near syncope. So when somebody has AT, what do we do about it? So if the AT is sustained and the patient is systematic because of that rapid rate, treatment is going to include applying a pulse ox. All right, so we're looking at their oxygen levels and their pulse and administering oxygen if needed, obtaining the patient's vital signs, making sure we have IV access, and making sure we get a 12-lead ECG as well. Now, if the patient is not hypotensive, remember hypotensive means low blood pressure, vagal maneuvers may be tried. Now, we'll discuss vagal maneuvers in a more detail later on, but what I just want to touch base on in regards to these are vagal maneuvers. They are they're rarely successful, but we may try them and attempt them in an effort to terminate that rhythm or slow that conduction of the AV node. Now, most likely they'll fail, but every once in a while they are successful. If they do fail, what we can do is assist with any antiarrhythmic medications for those patients that are hemodynamically stable. Adenosine can also be useful, and this can either help us restore sinus rhythm or diagnose that tachycardia in patients that may have suspected focal AT as well. Beta blockers and calcium channel blockers may be ordered to help slow that ventricular rate. And if that AT is sustained and causing persistent signs of a hemodynamic compromise, IV adenosine may be ordered as well. If it is ineffective or if administered is not feasible, what we could do is a synchronized cardioversion could be performed as well. So vagal maneuvers are going to be methods that are used to stimulate the baroreceptors in the internal carotid arteries and the aortic arch. So what happens is the stimulation of these receptors results in the reflex stimulation of the vagus nerve and the release of acetylcholine. Now, acetylcholine is going to prolong the effects of the refractory period of that AV node. So what will happen then is it will slow the conduction through the AV node and interrupt that reentrant circuit. All right, remember that circular motion that we saw in that slide when we were talking about the SVTs. So what you're seeing here in this picture is what we call a carotid sinus massage. And what a carotid sinus massage is, or what you may also hear as carotid sinus pressure, is a type of vagal maneuver that is performed with the patient's neck extended. And what we do is we apply steady pressure to the right or left carotid sinus just underneath the angle of the jaw for about 5 to 10 seconds. And when that pressure is applied directly, what it does is it stretches the walls of the carotid sinus. And when that happens, it stimulates those baroreceptors. The carotid sinus pressure should be avoided in those patients that are older adults, those who have a history of stroke. They might have a known carotid artery stenosis or a carotid bruit or auscultation. Also, simultaneous bilateral carotid pressure is not recommended. Because many organizations will also stipulate that carotid massage is only performed by a physician, it's important that you always check the policy and procedures on where you work as well. Adenosine is going to slow the rate of the sinoatrial node, which then slows conduction through that AV node. And it can also interrupt any of that re-entry pathway through that AV node and can restore sinus rhythm in those patients that have SVT. So re-entry circuits are going to be that underlying mechanism for many episodes of SVT. So adenosine acts as a specific receptors to cause a temporary block of that conduction through the AV node. And that interrupts that re-entry circuit. So a 12-lead ECG is recording is going to be important when adenosine is used. And adenosine has an onset of action of anywhere from 10 to 40 seconds, and it usually lasts about 1 to 2 minutes. So it has a very short half-life, right? So the medication is going to be administered typically intravenously and as rapidly as possible. So just over a period of a few seconds. And it's immediately followed with a saline flush. So what that means is they're going to put the drug in, adenosine, through the IV. And then as soon as that's finished, they're going to take saline and then push that through the IV directly after the medication's put in. Now, you heard me mention a synchronized cardioversion earlier in this lecture. What a synchronized cardioversion is the delivery of a shock to the heart through a defibrillator, and what that will do is terminate a rapid dysrhythmia. Now, a synchronized shock means that the shock is timed to avoid the relative refractory period of that cardiac cycle. So when the sync control is pressed, the machine is going to search for the QRS complex. And when it detects that QRS complex, the monitor is going to place a flag or a sync marker on that complex. What you might see is it could appear as an oval, a square, a line, a heightened triangle on that ECG display, that flag that we're talking about. So to deliver a shock, what's going to happen is you're going to press and hold that shock button on the defibrillator until a message appears on the screen indicating that that shock has been delivered. Now, standard paddles, what we do is we press and hold the shock control on each paddle until the message is seen. So it's really going to depend on the machine that you're using, but that's typically, that is how a synchronized cardioversion is done. Once again, this is typically only done by physicians. Always follow your policies and procedures. That is not something that we are going to show you how to do, and it's something that you would most likely never ever do unless you are trying to become a physician. Now, because that machine must be able to detect a QRS complex in order to sync, the synchronized cardioversion is used to treat rhythms that have a clearly identifiable QRS complex and a rapid ventricular rate in patients who show signs of the hemodynamic compromise. So examples of rhythms that may be treated with the cardioversion are going to be include narrow QRS tachycardias, AFib, atrial flutter, and monomorphic ventricular tachycardia. Now, elective cardioversion should not be performed in patients with evidence of any type of digoxin, I can't speak. I'm sorry, digoxin toxicity. If they have severe hypokalemia or any other electrolyte imbalances, until those factors or those underlying issues are treated and corrected. In AV nodal reentrant tachycardia, or we call AVNRT, and this is going to be the most common type of SVT. In patients with AVNRT, have two pathways within the AV nodes that are conducting impulses at different speeds and recover at different rates. So, under the right conditions, these fast and slow pathways can form an electrical circuit or loop. So, much like we saw in that picture, we had a big loop going in this one. As one side of the loop is recovering, the other is firing. So, typically, the AVNRT, which may be also referred to as slow fast tachycardia, is usually caused by single or even multiple PACs. So it is estimated that about 80% of AVNRTs are the slow fast type. So what this means is that a PAC, having found the fast pathway refractory, conducts the impulse to the ventricles by means of the slow pathway. So what we'll see this on the ECG is we'll see a prolonged PR interval. And if the fast pathway has recovered, the impulse can conduct rapidly up that fast pathway and depolarize the atrial. And what we'll see in that is an echo beat. That impulse can also re-enter the slow pathway to conduct again. So if that pattern continues, the AVNRT is initiated, and what this results in is a very rapid and regular ventricular rhythm. And what it will do is it will range anywhere typically from 150 to 250 beats per minute. Now, a less common type of AVNRT is going to be called an atypical AVNRT. This was also known as fast slow tachycardia. So an atypical AVNRT is often going to be initiated by a premature complex that conducts down the fast pathway and returns by means of the slow pathway, hence fast slow tachycardia. So how do we recognize AVNRT? First, the ventricular rhythm is usually very regular. Our rate, we're still in our tachycardia, is going to be high. And for this one specifically, we're going to see about 150 to 250 beats per minute. Typically, you're going to see it fall between 180 and 200 for most adults. So our P wave, once again, we're going to typically see this hidden in the QRS complex. And if those ventricles are stimulated first and then the atria, we may see an inverted P wave, meaning that it's negative or it's upside down, the opposite of our upright or positive P wave. And it will usually appear after that QRS complex in leads 2, 3, and AVF. When the atria are depolarized after those ventricles, what we'll see is that P wave typically distorts the end of the QRS complex. In AVNRT, our PR interval is not going to be measurable because we're not going to see that P wave before that QRS complex. Our QRS duration is the same as we've talked about in this lecture. So as you notice looking at this ECG, our P waves are hidden within the QRS complex. All right, we have our QRS, our T wave, and then right back to the QRS. We're not able to see that P wave. So, although AVNRT can occur at any age, we're typically going to see this in younger adults, and it occurs more often in women than in men, actually. So, whether a person is born with a tendency to have AVNRT or whether it develops later in life for an unknown reason has not really been clearly determined. We're not really sure. So, AVNRT is most often going to be seen in those young adults, and it's typically going to be found in young adults who have no structural heart disease or any ischemic heart disease. We may also see AVNRT in patients with chronic obstructive pulmonary disease, what we call COPD, CAD or CAD, valvular heart disease, heart failure, and even digitalis toxicity. So AVNRT can also be triggered by specific things. Some things that could possibly trigger AVNRT are things like hypoxia, stress, anxiety, caffeine, smoking, sleep deprivation, and many other different types of medications as well. AVNRT can cause angina or even myocardial infarction or MI in patients with CAD as well. So when our patient has AVNRT, what do we do about it? Because this is usually short-lived or sustained, the treatment's really going to depend on the duration of the tachycardia and the severity of our patient's signs and symptoms. So some things that we may find are things like chest pain or pressure, dizziness, dyspnea, heart failure, lightheadedness, nausea, neck pulsations, even nervousness and anxiety, palpitations, which is probably one of the most common, signs of shock, syncope, and even weakness. So if the patient is stable, but they're experiencing some of those symptoms, and those symptoms are a result of that rapid heart rate, we want to make sure we apply a pulse oximeter and administer oxygen if it's needed. So remember that pulse oximeter is going to give us not only our pulse, but also our oxygen levels. We want to obtain the patient's vital signs, make sure we have IV access, and make sure we get a 12-lead ECG reading on them. We're obviously going to continually monitor that ECG. We want to maybe potentially attempt a vagal maneuver if there are no contraindications present. Contraindications mean that there's a reason that we shouldn't do it, a reason that would be harmful to the patient. Remember, we talked about a patient that may have a stroke. We shouldn't do some vagal maneuvers like the carotid massage. Now, if we're allowed to do those vagal maneuvers, then we could perform them. However, remember, it's sort of rare that they actually work. So if they do not slow that heart rate or cause conversion of the tachycardia to that sinus rhythm, then what we would like to do is the first antiarrhythmic medication of adenosine is going to be given. The administration of calcium channel blockers or beta blockers may also be given if the AVNRT fails to convert to sinus rhythm or if it starts to reoccur. It's also been estimated about 80% to 98% of stable patients with SVT respond to medication therapy with adenosine as well as some other ones as well. Now, an unstable patient is going to be one who has these different signs and symptoms of hemodynamic compromise. So examples of these signs would be symptoms like acute changes in their mental status, chest pain or discomfort, hypotension, shortness of breath, pulmonary congestion, heart failure, acute MI, and signs of shock. All right? So those are different signs and symptoms of hemodynamic compromise. If the patient is unstable, treatment should include making sure we have that pulse ox, getting oxygen if needed, IV access, and sedation if the patient is awake and it's needed, followed by a synchronized cardioversion. So atrioventricular reentrant tachycardia, or AVRT, is going to be our next most common type of SVT. And the term pre-excitation refers to a rhythm that originates above the ventricles and transmits an impulse along a pathway outside of that AV node and the AV bundle. So what happens as a result of this, this supraventricular impulse excites the ventricles earlier than would be expected if the impulse had traveled through the normal conduction system. So once again, you're going to see normal sinus rhythm, just to give you guys sort of a grounding point. This is showing you normal conduction during sinus rhythm. So what it's showing is that the normal heart is going to spread from the SA node to the AV node, then down the bundle branches. And then that jagged line is going to indicate that physiological slowing of the conduction in the AV node. So that's why you sort of see a jagged line in that. Now, as we move down to Wolff-Parkinson-White or WPW pattern, what we're going to see is an abnormal accessory conduction pathway called a bypass tract, or BT. What this does is it connects the atria and ventricles. With the WPW, during sinus rhythm, the electrical impulse is conducted quickly down the bypass tract, pre-exciting the ventricles before that impulse arrives via the AV node. And then what happens with this is the PR interval is short and the QRS complex is wide, with slurring as its onset, aka our delta wave. Now with C over here, our WPW predisposes our patient to develop the AVRT. And so what we'll see is a premature atrial beat, and it may spread down the normal pathway to the ventricles, and then it's going to travel back up the bypass tract and recirculate down the AV node again. So this reentrant loop can repeat itself over and over, and that will result in that tachycardia. Now, if you notice with this one, the QRS complex often has a negative P wave in lead 2 during this type of bypass tract or BT tachycardia. So right here in C, you see that inverted P wave. In B, you see that delta wave and a widened QRS. So how do we recognize WPW on an ECG? Once again, our PR interval is going to be short. We're going to notice a delta wave, a widening of the QRS. So if you notice, these QRS are extremely wide compared to our other ECGs we've been looking at. We may even see a secondary ST and T wave changes. So how do we recognize our WPW pattern, our Wolff-Parkinson-White pattern? Once again, short PR interval, QRS widening, and the delta wave. All right, so we're going to compare this to a normal conduction. So as you can see, we have in A, in the left column here, we have our normal P wave, our atrial depolarization. We have our QRS that's normal, our ventricular depolarization, and then we have our T wave, which is our ventricular repolarization. Now, as you move over to the WPW column, or once again the Wolff-Parkinson-White pattern, all right, you're going to notice there's a delta wave present. So they sort of highlighted on here so you can see, all right, we don't have that inversion of our QRS. It now goes up because there's a delta wave present. I do also just want to note that those negative delta waves may simulate pathological Q waves, which can mimic a myocardial infarction. So how do we recognize these? So this is going to be a good example of what this looks like. Once again, we see the big widening of our QRS complex here. We can even see the presence of a delta wave. So let's start with these characteristics of our ECG. We'll first start with rhythm. We do notice that we're typically going to see a regular rhythm unless it's associated with AFib. Our rate is usually going to be 60 to 100 beats per minute. Our P waves are going to be normal and positive in lead 2, unless that WPW is associated with AFib. Now, PR interval. If that P wave is observed, we'll see 0.12 seconds or less. Our QRS duration is usually going to be more than 0.12 seconds. We'll see a slurred upstroke of that QRS, which is going to be that delta wave, and it may be seen in one or more leads. So what you're going to see in this rhythm strip is an example of that intermittent pre-excitation. So that first 3 beats, so pre-excitation, and then it's followed by abrupt normalization of that QRS complex in the next 2 beats, and the pre-excitation pattern returns for the final 3 beats. So the WPW syndrome is going to be more common among men than among women, and most people with WPW syndrome have no associated heart disease. The WPW syndrome is one of the most common causes of tachydysrhythmias, in infants and children. Now, although the accessory pathway in our WPW syndrome is believed to be congenital in its origin, symptoms associated with this pre-excitation often do not appear until the patient is a teenager or even during young adulthood. So basically what they mean by congenital, they mean that they were born with it, but they're not seeing these signs or symptoms or that until their teenager or young adulthood years. So some common signs and symptoms that are going to be associated with the AVRT and a rapid ventricular rate are going to be things like anxiety, chest discomfort, things like dizziness and lightheadedness. Once again, palpitations are going to be very common. Shortness of breath during exercise, signs of shock, and even weakness. So if we see a delta wave is noted on the ECG, but our patient's asymptomatic, they're not experiencing any symptoms, really no specific treatment is going to be required. However, if the patient is symptomatic because of that rapid ventricular rate, the treatment's all going to depend on how unstable the patient is. It's also going to depend on the width of that QRS complex, whether it's wide or it's narrow, and the regularity of that ventricular rhythm. As normal, we would always consult with a cardiologist when it comes to care for a patient with AVRT. As a reminder, vagal maneuvers are going to be recommended with the patient if they're stable and there's no type of contraindications. Medications can be given, there's going to be some medications that should be avoided in regard to this, such as adenosine, digoxin, are 2 of the common ones that should be avoided. These are going to be contraindicated because they slow or block conduction across that AV node, but they may speed up conduction through the accessory pathway, which could result in a further increase in that ventricular rate. Although the potential for beta blockers to enhance conduction across those accessory pathways is controversial, it should move forward with caution with these drugs, especially with AFib associated. And if the patient is unstable, preparation should be made for a potential of a synchronized cardioversion. Typical atrial flutter, which can also be known as common atrial flutter or even counterclockwise atrial flutter, is going to be caused by re-entry in which an impulse is going to circle around a large area of tissue, such as even the entire right atrium, in a counterclockwise direction. So these atrial waveforms are going to be produced, and they sort of resemble almost like teeth on a saw or even a picket fence to help give you a visual, as you can see on the picture on the right here. We call these flutter waves or F waves. And F waves are typically or predominantly going to be negative in our leads 2, 3, and AVF, and they're going to be positive in V1. Now, the atrial rate is typically going to range from 240 to 300 beats per minute. It's also important to note that because these P waves are not observed in atrial flutter, the PR interval is not going to be measurable. We're typically going to see that the QRS complex is 0.11 second or less because the atrial flutter is supraventricular rhythm and the impulse is conducted normally through the AV junction and the Purkinje fibers. However, if flutter waves are buried in the QRS complex, or if an intraventricular conduction delay exists, that QRS will appear wide. Now, with atypical atrial flutter, that impulse circulates in a clockwise direction. So this is atypical atrial flutter. It's now going to go in a clockwise, where typical atrial flutter was in a counterclockwise. So with atypical atrial flutter, the impulse is going to circulate, in a clockwise direction. And what that's going to result in is the F waves that are going to be predominantly positive in leads 2, 3 in AVF and negative in V1. The mechanism of atypical atrial flutter may be related to incisional scars from previous cardiac surgeries, especially those involving atrial tissue, previous atrial ablation, idiopathic fibrosis in areas of the atrium, or any other type of anatomic or functional barriers to conduction in our atria. So it is important to recognize that the F wave descriptions provided for typical and atypical atrial flutter are not always reliable with regard to the location of that reentry circuit or the type of atrial flutter. So, how do we recognize it? So this rhythm strip is going to show us a narrow QRS tachycardia with a ventricular rate just under 150 beats per minute. And the arrows are going to indicate on here the possible atrial activity. So our rhythm is going to be atrial is going to be regular, and our ventricular is going to be regular or irregular, depending on the AV conduction and the blockade that's there. Our rate, so our atrial rate is typically going to range from 240 to 300 beats per minute, so extremely high. The ventricular rate is going to vary and is going to be determined by the AV blockade. Typically, we're not going to see that exceed 180 beats per minute just because of that intrinsic conduction at that AV junction. We're not going to have an identifiable P wave, and we're going to have those sawtooth flutter waves that are going to be present, so those F waves. We're not going to be able to measure that PR interval either. So atrial flutter is going to be often precipitated by a brief episode of AT or even by AFib. So it may last for seconds to hours, and occasionally it's going to persist for 24 hours or longer. Chronic atrial flutter is going to be extremely unusual. Typically what we're going to see is that atrial flutter is going to convert to either sinus rhythm, or AFib, either through treatment or on its own. There are going to be lots of different conditions that are associated with atrial flutter, and those are going to be things like cardiac surgery, cardiomyopathy, chronic lung disease, complication of myocardial infarction, digitalis or quinidine toxicity, hyperthyroidism, ischemic heart disease, mitral or even tricuspid valve stenosis or regurgitation, pericarditis or myocarditis, pneumonia, or even a pulmonary embolism. So patients with atrial flutter are going to commonly present with complaints of palpitations, things like difficulty breathing, fatigue, or even chest discomfort. And the severity of signs and symptoms associated with atrial flutter are going to vary depending on the ventricular rate, how long the rhythm has been present, and the patient's cardiovascular status. So it's always going to be best, as always, consult with the cardiologist. Vagal maneuvers may help to identify the rhythm by temporarily slowing AV conduction and revealing that underlying flutter waves. So when those vagal maneuvers are used in the management of atrial flutter, what we're usually going to see is the response is sudden slowing and then a return to the former rate. So those vagal maneuvers will not usually convert atrial flutter because the reentry circuit is located in the atria, not the AV node. Now, if the atrial flutter is associated with a rapid ventricular rate and the patient is stable but symptomatic, treatment is usually aimed at controlling that ventricular rate with medications such as beta blockers or through non-dihydropyridine calcium channel blockers. Now, synchronized cardioversion should be considered for any patient with atrial flutter who has serious signs and symptoms because of that rapid ventricular rate. Once again, things like hypotension, signs of shock, or even heart failure. And if that synchronized cardioversion is performed, atrial flutter can be successfully converted to a sinus rhythm with the use of low energy levels. Now, atrial fibrillation or what we call AFib occurs because of the abnormal automaticity in one or several rapidly firing sites in the atria, or even re-entry involving one or more circuits in the atrium. So irritable sites in the atria fire at a rate of anywhere from 300 to 600 times per minute. And these rapid impulses cause the muscles of the atria to quiver. And then this results in an ineffectual atrial contraction, decreased stroke volume, a subsequent decrease in cardiac output, and a loss of that atrial kick. So the ventricular response to AFib is going to depend on the electrophysiological properties of the AV node and other conducting tissues. It's also going to depend on the level of sympathetic and parasympathetic tone, the presence or even absence of accessory pathways, and the action of drugs. So AFib may occur alone or in association with other different types of atrial dysrhythmias. So when we talked about how the atrial muscles begin to quiver, almost, our heart is like a well-oiled machine typically, right? In our normal state, everything works like a well-oiled machine. It pumps and it's very consistent. Now, what happens in AFib, our atria almost become like jello and they just sort of move back and forth. Nothing's really being done. That's where that quivering motion occurs. So what you see on this ECG is atrial fibrillation, or AFib, with a ventricular response of 80 beats per minute. So with the rhythm and ECG characteristics that we're going to see with AFib is 1, the ventricular rhythm is usually irregularly irregular. The rate, so our atrial rate is usually anywhere from 300 to 600 beats per minute, and the ventricular rate may vary. We're not going to have any identifiable P waves. We're going to have fibrillatory waves present, that quivering type waves. They're going to be erratic and have a wavy baseline. So you can sort of see how there's that baseline that is normally flat is very wavy. Our PR interval is not going to be measurable because we don't have any identifiable P waves. And then our QRS duration is be the same as we've talked about this entire lecture. So AFib can occur with third-degree atrioventricular block, And what we'll see is the ventricular rate is slow and regular because of this block. So typically when this happens is we usually suspect toxicity caused by digitalis, beta blockers, or even calcium channel blockers if the AFib occurs with a slow, regular ventricular rate. This can occur when a patient who has AFib is prescribed medications to slow that ventricular rate as well. So excess medication can cause third-degree AV block, and when AFib is present with a third-degree AV block, that diagnosis of AFib is made on the basis of the presence of F waves. So you see these F waves in here. Along with that ventricular rhythm will be slow and regular. Now, although most patients with AFib have some form of cardiovascular disease, it can occur in patients without any detectable heart disease or any relatable symptoms. So patients who have experienced, who do experience AFib are at an increased risk of atrial thrombus formation, which can lead to stroke, peripheral thromboembolism, or even both. So because the atria do not contract effectively and expel all the blood within them, the blood may start to pool within these chambers and form clots. So that's what we're talking about, the atrial thrombus meaning clot. And then the clot may dislodge on its own or because of a conversion of AFib to a sinus rhythm as well. Now, the reason we're going to have that increased stroke risk is exactly what it says on here. We're not having our atrium contract normally or effectively, and that blood becomes the pool. And blood pools, it starts to clot. And when that clot happens, it can be dislodged, and it can be moved to an artery in the brain, which can then cause that stroke to occur. So AFib may occur as a self-limiting episode. It may come and go, or it may exist as a sustained rhythm. Now, about 25% of patients who experience AFib are going to be asymptomatic. But when symptoms are present, the severity of the signs and symptoms associated with AFib vary with that ventricular rate, either too fast or too slow, and the loss of the effective atrial contraction, sympathetic activation, and even the beat-to-beat variability and ventricular filling. So treatment decisions are solely going to be based on the ventricular rate, the duration of the rhythm, the patient's general health, and how he or she is tolerating the rhythm. It is always best, as always, like we've said every single time, cardiologist needs to be consulted. So rate, control, and rhythm are going to be the two primary goals of treatment strategies when it comes to the controlling the symptoms of AFib. So with rate control, the patient remains in AFib, but ventricular rate is going to be controlled to decrease any acute symptoms, reduce any signs of ischemia, and reduce or prevent any signs of heart failure from developing. With rhythm control, sinus rhythm would be reestablished. That concludes our lesson on atrial rhythms. If you have any questions at all, please email me, k4 at h2health.com. Thank you and have a great day.